Well, thank you again for the kind invitation to speak today. And I'm pleased to be here to speak about some of our successes and challenges in using simulation over the last stormy 21 months of the pandemic. So today I'll be describing a framework for making choices and sacrifices in medical education during a pandemic. I'll explain the application of this framework within the context of simulation-based education. And I probably want to finish off by listing some of the successes and the challenges encountered while delivering sim-based education in the context of these pandemic-induced program modifications. So let me take you back to 2020. The World Health Organization declared the outbreak a public health emergency of international concern on January 30th and a pandemic on March the 11th. That evening, I had been scanning the news from states of emergency in Italy and New York and looking up PPE recommendations. I was thinking I should organize some sim sessions to prepare. I did not think that the very next night on March 12th at 1 o'clock in the morning, I would be intubating the first potentially COVID positive patient in Ottawa, a woman with an acute abdomen coming for an emergency laparotomy who had returned 2 days before from New York City with a fever and a cough. It was a bit of a blur. I knew I needed to glove, gown, wear goggles and N95. I knew we needed to intubate a negative pressure room. I remember reading something about concerns of the neck being unprotected. I had read about doffing and donning, but I couldn't actually remember the last time I'd actually done it. Long story short, I wore far too much PPE. I did not doff before transferring the patient from the emergency room to the operating room. I remember the entire operating room being extremely stressed. We kept our trainees out of the case, and post-operatively, I kept the patient intubated in ICU because we were not sure how to safely extubate the patient. To say we were unprepared was a gross understatement. The practice-changing implications of the pandemic were only just beginning, and the explosion in literature to follow was staggering. In fact, since that date, if you search for simulation and pandemic in PubMed, you get 4,593 results, over 90% published since 2020. And if you search simulation and COVID, you get 6,286 results, all since 2020. We are clearly in the midst of a global public health crisis, but as Albert Einstein said, in the midst of every crisis lies great opportunity. Simulation educators around the world seized this opportunity, and the use of simulation has been integral to the ability of healthcare personnel and healthcare systems to rapidly respond to this crisis, as you can see from the previous two talks. This paper by my colleagues in Alberta, Canada, is one example of what we've learned and what we've gained. But I think you can all agree that our learners have been equally as impacted as our patients and colleagues. For them, all formal educational activities came to a screeching halt when the pandemic was declared, and yet they still needed to learn and progress in their training. So how do we make these choices in education, and what do we choose to sacrifice? This paper was a collaboration between educators in Denmark, Singapore, New Zealand, and Canada, and in it they outlined a framework for making these difficult choices and sacrifices. Now, this table in the paper summarizes the considerations for making these decisions. It's difficult to read, so I've taken the liberty of simplifying it here for you. So first of all, we have to consider what can we continue intact no matter what? What can we postpone, but it still needs to happen as is? What can be adapted, changed, or run in a different way? What can be dropped entirely? And finally, what needs to be added? And for each of these 5 areas, we need to determine how to enact them, the impact of doing so, explore the options, opportunities, constraints in doing it, and consider what worked, what did not work, and what can we learn from this. So what I'd like to focus on next is the impact of using this framework on sim educator responsibilities and obligations in the initial phase 1 of the pandemic in Ottawa, Canada. And this is an overall summary of what we decided to continue: summative assessment. We postponed our formative assessment. We adapted our scenario implementation and debriefing. We dropped our trainee interprofessional simulation, and we added faculty interprofessional in situ simulation to our practice. So I'll outline some of the challenges we faced, some of the surprising opportunities that were presented to us, and how our nimbleness has changed our educational practice. So I'll start first with what we added. So as you all know, at the beginning of the pandemic, there was an onslaught of change in almost every aspect of how we care for patients in the operating room environment. We needed to provide opportunities for our staff to practice, working in different locations, wearing uncomfortable and time-intensive PPE that made it difficult to see the patient, see and hear each other in our monitors. We had to perform a different sequence of actions using brand new surgical safety checklists, a new cognitive airway aid, and nothing was the same as before. And what we needed to focus on were the foundational aspects of our everyday practice. We needed to pull it together fast. We needed to do it well. And since the Ottawa Hospital is one of the largest tertiary care centers in Canada, with over 1,271 beds, we needed mass delivery. The logistics were a massive undertaking, like Mount Everest. Normally, we meet with stakeholders over weeks to months prior to implementation to determine the educational needs, develop the scenarios, ensure we have the proper equipment, and we do a practice run of each scenario with all stakeholders present and work out all the kinks. With the rapid response pandemic readiness training, we created the surgical safety checklist and the airway cognitive aid. We created new operating room standard operating procedures. We developed the scenarios. We did not do a dry run, and we started to deliver the entire initiative within 4 days, which we developed over the weekend after Canada closed its borders in March. And like Everest, it was a massive undertaking that involved a massive amount of people, and it required a big push at the end. The IPAC and PPE training began 3 days after mobilization. Simulation training launched 2 days later, taking into account all of our evolving protocols for infection control, airway management, checklists, and perioperative patient flow. We ran 2 scenarios, a stable COVID positive patient presenting to the operating room for emergency surgery, and an unstable COVID positive patient presenting in the emergency room that required urgent intubation. So our successes, well, we trained 150 staff in PPE donning and doffing procedures over 2 days. We enabled some of them to become PPE champions to continue faculty development over the course of the next few weeks. 239 staff participated in the simulations over 3 days, 99 anesthesiologists and 34 surgeons, all staff, residents, and fellows, and 106 additional healthcare workers, including nurses, anesthesia assistants, and operating room attendants. The feedback from the participants was very positive, and better yet, I was able to generate a list of crowdsourced suggestions for improving the environment and working protocols to feed forward to hospital senior management. And training at both sites of the Ottawa Hospital perioperative staff was done 7 days after our very first group meeting. However, there was a challenge that we did not expect, an unintended consequence of our mass delivery of simulation training to our colleagues. About 4 days after the simulation training, our simulation educators were informed by the hospital occupational health and safety that one of the simulation participants was being tested for COVID. All healthcare workers who came into contact with that individual needed to be risk stratified by the occupational health according to the time spent in close proximity, the type of interaction with the index participant, and they were given instructions on how to proceed to self-monitor, self-isolate, work or not work. And because of Personal Health Information Protection Act, we were not given any details on the participant, their symptomatology, the reason for testing, or outcomes of contact tracing. And as you can imagine, this created a great deal of distress amongst all of the people affected, in addition to the impact on staffing in the hospital. And as far as I know, the test came back negative and there were no transmission between individuals. So I just want to point this out because the risk to simulation participants have rarely been reported and generally overlooked. And the usual risk to healthcare workers during training via simulation has really been focused on psychological safety consideration, as Dr. Cheng outlined in his talk. I don't have time to go into some of the details here, but if anyone's interested in our suggestions on mitigating risks of virus transmission during simulation-based pandemic training, we've summarized them in a table in this paper, which you can access via the QR code. So subsequent to this, we pivoted to the creation of 360 spherical videos of these scenarios. And here's an example of a still shot of one of our 360 spherical videos. And this particular clinical situation is the awake tracheostomy on an awake COVID positive patient. So the inset in the top left corner of the screen shows the view of the procedure, while the main screen shows the interactions between the surgeon, the anesthesiologist, and the surgical assist. The arrows on the top corner indicate how you can move the view using the arrow keys on a keyboard. Otherwise, the easier method is to use a mouse. Or if you have a VR headset, you can also watch the videos on a VR headset. And these training videos, along with others that we've created, are freely accessible to anyone who wants to view them. We now have 17 videos on our website, and some of the topics are shown here. You can also access this website via the QR code. So on to some of the other choices and sacrifices we had to make. And I'd like to leave the discussion of what we needed to adapt to the end of our talk. We decided to continue summative assessment and postpone our formative assessment and drop our interprofessional simulation. And you may be asking yourself, given the sudden absence of clinical exposure for our trainees, as we were on lockdown and doing life and limb surgeries only, why did we choose to continue with our summative assessment simulation and postpone the others? Well, a little bit of this requires a bit of background on our training program. We transitioned to a competency-based residency training program in 2015, 2 years ahead of the rest of the anesthesia programs in Canada. And one of the backbones of CBD, or self-competence by design, is frequent and multimodal assessment. Assessment in CBD can be supplemented by simulation, which, as you know, sits at the shows how level of Miller's pyramid. And we integrated sim-based assessment of competence into our program as a way of providing robust assessment data to our competence committee. And they depend on this data and they use it to make promotion decisions on whether to advance residents to the next stage of training. So put another way, let's review some of the tenets of a robust assessment program, indicated here by the carved mnemonic. So C stands for several things, first of which is cost effectiveness. Any assessment model needs to consider the related costs, practicality, and feasibility. We need to make sure that there's cohesion of different assessment pieces being used in the program. We need to make sure that all the relevant competencies are addressed in a comprehensive way in the program of assessment. The assessment model needs to be acceptable, not only to the learners, but also the specialty, the faculty, the certification body, and the society at large. We need to make sure that the consistency of the decisions being made are high, as well as making sure that the assessment itself is measuring what it intends to measure regarding the validity. And finally, we know that assessment drives learning. So it's important to make the assessment worth learning towards. And learners improve by preparing for the assessment and learning from the feedback we provide. And so from that, there's a subsequent catalytic effect to improve educational systems. So given that this table here, I've modified from Norcini's consensus framework for good assessment, and it shows the relative importance of each of these tenets of good assessment when used for formative versus summative purposes. And in looking at this table, given that we were hoping that the lockdown and pandemic impact would be short term, now remember this was back in 2020, March 2020, it was clear in our eyes at that time that the summative assessments would be prioritized in our program. So what did we postpone? We postponed our formative assessments, and for us this meant our weekly PGY 2 to 5 simulation assessments. We dropped our interprofessional components of our trainee simulations, because normally we have over 2/3 of our simulations run with surgical residents, with operating room nurses, with anesthesia assistants. We decided to continue all of our summative assessments, which accounted for a summative foundations OSCE for our PGY 1 and foundations crisis resource management OSCE for our PGY 1s, which we use to determine their ability to take independent calls. We also continued our ACLS competency, which we run on a surprise ad hoc basis for all of our residents throughout residency. And we continued with our CANASC, or our Canadian National Anesthesia Simulation Curriculum, for our graduating residents. And this simulation assessment is a component of certification for the Royal College in Canada, and we felt that was obviously a priority to continue. So finally, what did we adapt in our simulation-based educational practice? We adapted our simulation implementation and our debriefing. And so to provide some context to this discussion, I'll just outline the impact that the pandemic had on our Sim Center operations in Ottawa. So in the spring of 2020, our Sim Center closed and went on immediate lockdown. Everything that could go virtual went online, mostly for us, our junior trainee foundations bootcamp lectures and teaching. We had instant adoption of our 360 spherical videos via the VR camera acquisition, as I've already described. And we launched our Insight Chiu pandemic readiness training for our faculty. In the summer and the fall of 2020, we reopened our simulation center, but we were only allowed markedly decreased numbers inside together. And this resulted in an increased number of groups with increased faculty needs and it highlighted a need in our department for more educators. It forced us to trim down and prioritize our curriculum, as I've described. And we needed so much flexibility in everything that we were doing, especially with respect to the scenario implementation, which I'll describe in a minute. We also switched to virtual teaching of our simulation fellows, and I'll go into that a little bit as well. And I know that Dr. Cheng has already well described virtual debriefing. In the winter of 2020 and the spring of 2021, our simulation center was seconded by public health as Ottawa's only vaccination center, at least until March 2021. And that moved us down to the basement of our simulation center. So we were relegated down to 2 rooms. We had no cameras, no control room, no debrief room. It was a large closet. We still had to do our Can Ask and other assessment center sessions in the basement with no recordings. And fortunately, we have very sim experienced and highly adaptable learners. And in doing so, we had to take into account several factors, which I'll be describing. In summer 2021, we actually continued as a simulation center, as a vaccination center until well into the August of 2021. And then we finally got back into our usual space at that point in time. And currently in the fall, winter here, where we're running in our usual space with modified numbers. We've resumed our interprofessional simulation, but unfortunately, due to the clinical burden with ramping up in the operating room, we've had, it's been difficult to have our allied health and nurses participate with us. So let's go into some of the details about the scenario implementation. So due to the loss of clinical exposure for our residents, we strongly advocated for simulation-based training in midst of a time when the hospital and public health would not even allow us to gather together in a conference room. So fortunately, we had very strong advocates. But when we did eventually begin to offer formative sim again, the one word that comes to mind is flexibility. We had rapid changes in our staffing with increasing and decreasing numbers due to the need for isolation and self-monitoring that came up depending on whether or not they'd been exposed to a COVID exposure. It forced us to write scenarios that could flex with the changes in the participant numbers, in the staffing numbers, in the location that we were running our simulations in. For example, we ran a 2-mannequin trauma simulation with 4 trainees, 6 fellows, 3 staff, and a simulation operator in one large conference room. Not what we're used to by any means, and we'll talk a little bit about the realism issues that came up. We had to implement COVID-related changes to the simulation scenarios, especially regarding AGMPs and cardiac arrest arrangements. We had to include goals of care discussions with our sim scenarios. And we really had a lot of investment by our faculty in adjusting to the scenario implementation on a daily basis. The other thing I wanted to bring everyone's attention to is the pandemic pre-brief, is what I call it these days. And in addition to the usual emphasis on the variety of issues in the pre-brief, we really had to reinforce the fiction contract, asking people to suspend disbelief and previewing a little bit about what could be expected, especially when we were running in the basement of the sim center. We had to make sure that we gave reassurance for IPAC concerns. Physical safety, hand sanitizer was a normal prop in our center. And we addressed all aspects of realism very, very carefully. And by realism, I mean the physical, conceptual, emotional, and sociologic realism. And if you want to read a little bit more about these types of realism, I direct your attention to these 2 papers here. And physical realism was a challenge. We were doing simulation in conference rooms, in basements. There were none of the usual physical props or equipment that we had to try to help with buy-in. We weren't initially allowed any gowns on the mannequin because we were worried about fomite transmission. The emotional realism was extremely heightened in the scenario because everyone was imagining what would happen if this really was a real patient with COVID. And so that was quite profound. And the sociological realism was in jeopardy because we didn't have the interprofessional simulations and we weren't sure, even if they were scheduled to come in with us, if they'd be able to show up. We had an unpredictable loss of participants, and that affected the sociological realism in our scenarios. In our adapting to debriefing, we actually kind of needed to do a little pre-brief of our debrief, again, to acknowledge some of the physical safety requirements and reassurance. So not just the emotional or psychological, but also the physical. We did wellness checks as a regular part of our debriefing, and that's actually a real important part of our debriefing now, and one of the successes that I'll talk about. We switched to virtual teaching of our simulation fellows. And so Dr. Cheng talked a little bit about debriefing virtually, but we ended up figuring out a way to teach our fellows how to debrief virtually, and then we taught them how to debrief their debrief virtually. So we've continued with this online, and we were about to move back to in-person sessions with our learners, but then the Omicron variant. And as you know, just last week, the Omicron variant surfaced, and in Canada, the first cases were detected in my city of Ottawa. And daily headlines are exploding, and it looks like we may be bracing ourselves for another COVID storm. So it's really critical that we look to our successes and we remember the challenges that we overcame when we're faced with ongoing waves of the pandemic, I think. And so I just want to spend a few minutes to outline some of the successes that we had. So the first was that for the first time, we prioritized faculty-based simulation CPD over trainee education for the first time, and there was huge uptake by our clinicians. We strengthened our community of practice of simulation educators. We had buy-in from skeptics who never would have participated in simulation had they not felt a personal threat by the pandemic. And the hospital senior leadership greatly valued our contributions. We empowered our faculty to be PPE champions, to teach each other, to use the 3R videos for continued learning. We were able to justify and continue our high stakes, high quality simulation assessments, and we had very little loss in our formative sim program, fortunately. And finally, the wellness checks that we have in our debriefing is now routine, and that's been a really important point of making sure that we boost morale and wellness in our program. Some of the challenges, well, mass delivery of sim leads to physical risks of COVID transmission, and we learned that firsthand. We needed to ensure physical safety, and that's been top of our mind whenever we run our simulation scenarios. We had suffered educator burnout and fatigue. With the constant scenario revisions, the flexibility in implementation and debriefing, on top of everything else that was going on clinically and personally and professionally, it was very, very difficult. And we really, on the flip side of that, I think it really brought us quite much closer together, as I've indicated, as a success. But I think that was the important thing for us to recognize. And finally, it was a challenge to be able to teach how to debrief virtually. Again, we've become quite accustomed to that. So over the last half hour or so, I've described how we've described a framework for making choices and sacrifices in medical education, specifically within the context of a simulation-based environment. And I've listed some of the successes and challenges encountered while we've delivered simulation-based education in the context of pandemic-induced program modifications. The pandemic has really brought into clear focus the underlying rationale and the fundamental advantages of simulation-based education. And seeing as the origins of sim-based education were in crisis resource management, I'll leave you with these words from Bill George, the former CEO of Medtronic, who wrote in his Wall Street Journal article, 7 Lessons for Leading in Crisis. Never waste a good crisis. When things are going well, people resist major changes or try to get by with minor adaptations. A crisis provides the leader with a platform to get things done that were required anyway and offers the sense of urgency to accelerate their implementation. So I'll leave you with those words, and I thank you very much for the opportunity to speak with you today.